Good morning, everyone. Today I will present a case for the EGM conference. I will begin my presentation. It's a 32-year-old male. He presents with a complaint of palpitation, which the patient having experienced last 10 years. And each episode lasts approximately 5 minutes. And these episodes occurs around 2 times a week and are characterized by sudden onset and sudden offset. And also he underwent RFCA for the AVNRT on February 6, 2024. And this is documented ECG, and variable Holter shows narrow QRS complex tachycardia. And this is sinus written 12-lead ECG. And chest X-ray shows no cardiomegaly. And transthoracic echocardiography revealed normal size cardiac chambers and normal global LV systolic function, ejection fraction 62%, and normal LV filling pattern. Now I would like to present the electrophysiological study. And this is initial catheter position, RAO and LAO beam. 2 quadrupolar catheter was placed at RV and his area respectively, and duodenal polar catheter was placed at RA and coronary sinus. And basics rhythm was normal sinus rhythm, and cycle length was 864 milliseconds. AH interval was 73 milliseconds. HV interval 52 milliseconds, and QRS duration 91 milliseconds. And during the RVP 500 milliseconds pacing, the earliest atrial activation was H34. And VA block cycle length observed during RVP 300 milliseconds. And there was no VA decremental property during single ventricular extra stimulus. And Kent ERP was observed during single ventricular extra stimulus 600, 300 milliseconds. And VERP was observed 600 and 220 milliseconds. And after that, we started atrial overdrive pacing, and AV block cycle length was during the RAP 460 milliseconds, and AV node ERP was observed during single ventricular extra stimulus 600 and 490 milliseconds. And AH jump and single echo beat was observed during single atrial extra stimulus. And narrow QRS tachycardia was induced by double atrial extra stimulus test, and tachycardia cycle length was 273 milliseconds, AH interval 110 milliseconds, HV interval 37 milliseconds, QRS duration 78 milliseconds, and VA interval was 71 milliseconds. This is tachycardia surface ECG. And we extract the advance following a signal, we reset positive. And entrainment pacing at RA apex exhibited 100 milliseconds PPI minus tachycardia cycle length and showed VAV response. And VA interval was measured during the RA apex 144 milliseconds, and during the RA base pacing 99 milliseconds. In other words, VA interval was longer when pacing at RV apex than RV base. And delta VA measured STEAM 2A during the entrainment, and VA during the SVT was 64 milliseconds. And also we measured local VA index. Local VA index was measured VA interval on the C8 catheter is measured during the entrainment and during the tachycardia. So we measured the earliest atrial activation CS34 VA interval during the entrainment 44 milliseconds, during the tachycardia 45 milliseconds. And parahesian pacing showed same STEAM 2A with his capture and without his capture is same. And tachycardia was terminated by AV simultaneous stimulation. And in the summary, the earliest age during RVP, age 3-4, and no VA decremental property. And narrow QRS tachycardia was induced by double atrial extra stimulus and AH jump and single echo beat. V reset positive. PPI minus tachycardia cycle length less than 150 milliseconds. STIM2A minus VA interval less than 85 milliseconds. Paradisian pacing less than 35 milliseconds. And VA time was longer when pacing at RV apex than RV base. And local VA index less than 40 milliseconds. And with impression, orthogramic AVRT, postural septal accessory pathway, and dual AV nodal physiology.
And a question about the EP study result? Where did the patient undergo the first ablation procedure? Here?
So question is that in the presence of a dual AV nodal physiology, which one is the active tachycardia? AV nodal reentry, or it is with a bystander pathway, or the pathway with a dual AV nodal physiology? Did you think that you answered that question? I'm asking two possibilities here. Patient can have a dual AV nodal physiology bystander orthodromic AVRT as the primary, or do AV NRT with the bystander auxiliary pathway. So how do we differentiate that? It can happen, so you better not get confused about it. Ablation standpoint probably wouldn't matter. In second case, if you have an AV NRT with the orthodromic AVRT, you can ablate both. But if you have an orthodromic AVRT bystander dual AV nodal physiology, you're going to ablate the pathway only. So this is the practical question I'm asking. Okay. So how do you differentiate? That's what I'm asking you. And based on your evidence you've shown to us, you think that the dual AV nodal physiology is passive phenomena? Yes or no? That's what you should answer, right?
Yeah.
Yes. Okay, you think about that. Okay, go ahead. Go on.
She shows the.
I know she showed that.
Yeah, high output the extra beat and terminate tachycardia. That means the accessory pathway contributes to the reentrance circuit. Maybe
it is a part of a tachycardia circuit. That actually the US EP board question I'm asking you. If you go take a board exam in EP in US, they will ask that question every single year. As an EP guy, you should know that, how to differentiate the maneuvering. Okay? All right. Go ahead.
After that, the RA and LA 3D geometry and activation mapping were then using HD grid catheter under V pacing. And this is RA local activation time mapping. And there is the earliest atrial activation site is located the RA postural septal area. And this is RA propagation mapping. The propagation started from RA postural septal area to superior septum and anterior wall.
I don't understand the anatomical relationship at all.
What is the CS located here? What is coronary sinus? Okay, so you need to go back, take a look at where the CS also is and all that. Okay.
Looks like a Stone Age rock.
No. I think I'm assuming this sticking out to the anteriorly the right side picture, that probably posterior view of the coronary sinus. I think I'm guessing, but anyway, you need to confirm that. Okay.
This is RA, the earliest activation signal site, postural septum area.
Okay, LA mapping now.
LA mapping.
Okay.
Station mapping.
Okay.
This is final RA and LA mapping.
Okay.
And after that, we started ablation, and this is ablation catheter position at the left postural septal area.
Okay.
And this is pre-ablation signal during hypertrophy. And this is pre-ablation signal during RVP 600 pacing
Mhm,
and showed ablation distal signal faster by 21 milliseconds.
mhm.
And during RF1 with RVA pacing, accessory pathway was blocked within 12 seconds.
Mhm.
And this is ablation catheter position RV RA posterior area
Mhm.
and pre-ablation signal during RVP and ablation distal signal faster 14 milliseconds. And
14
during
milliseconds earlier than what? It's tricky.
yes, yes,
Okay, so you should mention about the reference.
and during their ablation, accessory pathway was blocked within 5 seconds. And this is final ablation type. And this is after the ablation, after adenosine, VA dissociation was observed during LV pacing. And also VA decremental property was observed during single ventricular extra stimulus. And this is after ablation, sinus rhythm ECG.
Can you show me the final success ablation site and fluoroscopy? That's this row. This one. It is right side, right?
Right side or transseptal? The right side septum?
Right side septum or the post left side septum?
Right side.
Right side.
Yeah, the
So
LA
inside
view.
the CS
LA
or-
view looks like almost inside the CS. Looks like at the mouth of the CS, CS also.
Yeah.
Okay, let's go back to your tracing photo from the beginning. Let's go, AP study. I'm just gonna make a few comments for you for the future, just for the learning, okay? All right, so no, keep going back. You show the catheter placement, okay, right there. Why you having this confusion? Let me put it this way. What do you think is happening? Why your RV patient could not differentiate between pathway and AVNRT? Look at the way you're pacing. Where you think that your RV catheter is? You said RV apex. It's not too, it's far away from RV apex. So where you think you're pacing? Invariably, you're gonna capture right bundle here, okay? If you capture right bundle, since the pathway to a retrograde AV conduction is a competitive phenomenon, you're gonna favor for what? Nodal conduction. Then you will muscle the left side far away pathway. So every single time. This is the commonest mistake fellows make. So if you're gonna do EP study, you have a primary goal, most common tachycardia to be left side pathway versus the AVNRT. Where do you want to pace? Posterior base. Your catheter should curve like this scenario, pointing down. So further away from conduction system, so you can differentiate. Okay? Or outflow tract pacing, for example. You're going to come down far away, have to turn around, go back to the RV. So if you're going to differentiate left lateral pathway, I favor for outflow tract pacing. That reason. If you think that the patient a posterior pathway in a LAO view, left side of 430 posterior, base pacing, never septal pacing. It's a basic concept of pacing. You need to understand. So don't put a catheter in the septum. You think pacing RV. So catheter placement is a very specific indication-oriented procedure. That's a fundamental concept of SBT evaluation. Okay, that's number one. Let's go to next. So their baseline measurements are fine. And then you have here, keep going. Keep going. So keep going. Okay, keep going. Here, what happened here? You said the patient has HR pacing. HR pacing did what here? You said that there was AV block. There's an AV block here. What happened? I want you to look at, tell me what is the third bit after that happening. Did that atrium capture? The number one question. Did not capture. That's a pseudo fusion, what we call. You already had the echo bit there. Number 4, complex A is an echo bit. It's not a pace capture bit. Okay? You should have seen that already. And what is unusual about this? If this was the slow pattern conduction, what would you see? You would see H56, such a tight, high frequency spike right at the QRS complex? Never. That does not happen. That's the first indication that there might be pathway here. Do you see that signal? You can amplify, magnify, take a look at that small notching high frequency signal.
So which lead? 5-6?
5-6, yeah. Which is also is in the next bit. Next, we go to next bit. Back to the V, there's a notching. No other bit has that. I'd said the occasional conducting, local concealed conduction will be known pathway. Okay? It is very important to notice those changes. It's coming, going. That because the CS cat moving a little bit around. Okay?
If it is nodal echo, I saw frequently the polarity change of proximal CS, but it is almost
same. That's exactly right.
Is it also different?
Fusion, yes, deposit, yeah. And other issue that if you look at the septal A activation here, which is, he says not well visible, but fell right into that spike, looks like pacing spike artifact. That's what you cannot see. Is later. So I think it is a certain feature that you want to look at it carefully, because that's non-capture, non-paced bit, the QRS relationship will give you some clue. Okay, and then which you can see that in surface ECG retrograde P. There's a retrograde P in the surface ECG. BA timing is a little bit longer than you like to see for the AVNRT. Okay, so look carefully every EGM before you. Okay, go to next. Keep going. Okay, so you said the patient is non-decremental and blocked here. AV nodal conduction here is fine, and there was a patient had a distinctive jump.
Yeah.
And how long was the jump? Keep going. So this echo bit there, we saw same thing. Keep going. Okay, this is just tachycardia. Keep going. Keep going. With the jump, the dual nodal conduction here, you said. Here? So, in other words, patient would have a retrograde conduction through the only when you have a dual nodal physiology. Also, when you have an echo bit, also the single nodal physiology as well. How do you explain that? Patient has multiple echo, multiple jump. In other words, if you had a dual nodal physiology, echo bit makes sense. But the first one is 40 millisecond or longer, shorter, but has still echo. How do you explain that? That would be another finding that against the AVNRT possibility you're discussing. Okay, so typically what would you see? You would see short PR, no echo, jump, and then subsequently echo bit. That would be a normal sequence of dual nodal physiology, unless patient has a multiple slow pathway. Okay, but even the multiple slow pathway would not make any sense. Still continue the same sequence. PR get progressively longer as the extra stimulus comes on, then jump, then you would have echo. Here, you're showing me two AV nodal conduction, fast and slow, I assume, with the same echo. That would be inconsistent with the AVNRT, right? So that's a minor observation. I'm just making things. Okay, let's go. But all the maneuver, I think you did very well. Just advancing A, and then basically showing that whatever tachycardia is involved in this activated sequence. Okay, yeah, that's the same thing. Okay. So if you look at this tracing here right now, then the tachycardia, where the earliest retrograde A, H34?
Yes.
Right? So why did you say this is a posterior subtle pathway? I'm confused about that right now. Is that your CS cat wasn't the further lateral? Minus the initial picture you showed to me? CS location, it changed? CS location got changed somehow? I'm just, look at that, with the H34. We don't call this posterior subtle pathway. This is a posterolateral pathway. Okay, maybe posterior could argue, but no, this can be because LAO at 35-degree angle. You got activation between 3, 4, 5, 6. That between 2 is the earliest coming back and forward. So more like almost like a free wall going to the posterior would be maybe 5, 6 to 7, 8, and the septum would be beyond that. So unless so, next time when you have such a question, I recommend you to see us venogram for your learning standpoint view, because it's all this maneuvering is your learning. Okay, keep going. Yeah, yeah. So this is a teaching conference. Okay, we are not trying to point a mistake. No, we are trying to teach you guys what to do now, not to the next time. Okay, here again, 3, 4 is earliest, right? So if you look at it carefully, I want you to tell me why is a B pacing, CS activation between 3, 4, 5, 6 during the tachycardia go to 3, 4. Did you notice that? But that between that 3, 4, 5, 6, the small spike thing I pointed earlier is there, 2 electrogram. You see that?
Point by mouse, please.
Yeah, no, that guy, before that guy. Okay, I'll go there, show you. Okay, leave that. I'll show you. If you look at this potential here, this potential, this is positive, this is negative. Same guy. You see that small fragment signal? Have you noticed that? Question is, why is that? That's probably where the pathway break through between 2. Okay? When the pathway insert to the atrial side, always have that fragment signal most of the time. But that's not a pathway potential though. Okay? Pathway potential probably close to the V side. But that's whenever break the electronic state change, direction of impulse change, you create this fragment signal. Sonny Jackman described a long time ago about this phenomenon. So people unfortunately think that's a pathway potential, target that. A lot of time works because you're oblating large area. That's why. When we
the targeting the 5, 6 CS 5, 6 is better.
Better than
Right.
exactly right.
Yeah.
Because the oblique pathway. Remember, right.
Local is earlier, but the
Right.
actual
Target would be close to 5, 6. Because
5, 6.
yeah, remember that the left side pathway, proximal ventricular insertion is more posterior, atrial insertion is more lateral. Most of pathways are. Okay, so that way, you're thinking that anatomic relationship, you want to ablate that area. Okay.
Very, very important.
Okay. Keep going. And in my determination, you do AV pacing simultaneously. You prove that this is basically tachycardia that require A and B. This is a diagnostic of what? Rule out the AV-NRT. If this AV-NRT is driving left bystander pathway, would not terminate. Okay, then you'll be very confused. Tachycardia could just go and reset, maybe just goes on. Because AV-NRT does not need the A, does not need the B. Okay, it's a fundamental maneuvering that's sometimes very useful for you to differentiate. Okay, very good. So the question is that your 3D, forget the 3D mapping, okay? This is not really helpful to us, your standpoint view. You're not going to do 3D mapping in Mongolia, do you?
Yeah.
So you're going to use it through 2D. All need to learn how to learn the 2D. Okay. So here is very clear, B pacing. You can see septal laser activation later, then you'll, right? CS 5, 6 clearly. So.
But this time, left side posterior septal ablation was successful, but they recurred.
Recurred, yes.
Recurred.
Recurred,
I
and
see.
then.
And I'm going to point out to the last question for you to think about it. Okay, so you're successful. Show me your tachycardia tracing one more time. I'm just going to make it a little more confused now, but you need to think about this, what I'm telling you. Right there, leave it there. Okay, if you look carefully, left lateral pathway, some of the pathway, AV, orthodromic tachycardia, AV relationship, space, timing, sometimes widely separated. Some of them like this almost lines up. Okay, have you noticed that? Some of it a lot more eccentric. VA timing eccentrics are pointing just specific area. This one, A activation is pretty much the entire CS catheter is just a little bit different. Have you thought about why is this? It's an important question because this type of a pathway is much harder to ablate. The reason is this is a broadly inserting axillary pathway. Okay, otherwise you can explain this. Why the fused area of lateral atrium activating almost in time? Because this is a probably branched pathway. So sometimes you will see pathway, but A and B almost together. Okay, so I think a difference of timing between A and B tell you what anatomical location of the CS relation to mitral annulus. That's what they mean. Even the activation timing is different, but then your pathway basically inserting wide region, so then atrium activated broadly. This type of pathway much harder to ablate than one that is very eccentric, very typical, easier to ablate. That means small localized insertion. This is a little bit more broader insertion. That's why. Okay, think about those things, please. So when you have this type of pathway, you really want to map well before you ablate. That I think would be the message here to minimize the number of burn. Okay. Yeah.
Dr. Wang, long time ago, you published in JACC
Yes.
the almost opposite cases.
Mm-hmm.
You ablated the AV node
Slow pathway.
Yeah, slow pathway ablation,
Mm-hmm.
but the actual successful site is similar site.
Similar size.
Serial posterolateral.
Posterolateral.
Right?
Yeah.
So if you retrospectively thinking about the mechanism,
Mm-hmm.
is it related to the left side slow pathway or the left accessory pathway with decremental conduction?
No, I think it's a lapse. It is a tachycardia that we could not terminate by AB pacing simultaneously.
Mhm.
We could terminate with a triple pacing, CS, RA, and RV. So showing that the CS is involved with a little bit more depth. But definitely is not a pathway because you could not terminate by the, could terminate by the, AV pacing in pathways. AVNRT you cannot terminate. Now, leftward extensions, sometimes I think length can vary patient to patient. It's rare, but those patients we ablate had the multiple pathway, so slow pathway, I mean. So I think most of them can be ablated right side posterior septum, like a normal area. But then some of those cases you need to go left side, and then you need to look for exit site of earliest A, unfortunately, similar to the pathway, except you're going to be much more posterior than typical AVNRT cases, a little bit higher too, might be. So aerial view, you looks like almost left side, the slow pathway area. And those are most common successful area. And I think part of that we think, I mean, I'm thinking back that years ago, I did not think about that. Rightward extension can travel inside the septum, different depth in terms of right to the left side septum, considering triangular pyramid here. So mostly come to the right endocardia closely to the right posterior extension. But some of the patient, I think the right posterior extension comes straight down middle of the septum. So it would be end up right top of the CS roof, or more toward the left side, more accessible than tachycardia circuit would be closer to the left side. So those one are actually is harder to ablate, as you know. So that's some cases we once in a while find the AVNRT. You don't find the good slope at the potential. You can burn, nothing happened to those cases. Those are usually end up burning right at the CS mouth roof or either a little bit inside the CS. Dr. Jackman does not really agree with that because he's worried about the heart block because you're burning the roof of a CS. It's on this patient because the CS they're wider than typical AVRT patients. So you actually could be right under the floor of the compact node. You're burning right through it. So I agree with them. So I think if you want to burn there, you want to burn low energy and make sure there's no junction rhythm right away. If you hear the junction right away, you better stop because you're injuring the compact node. So I think some of the experience is required to do that. So rather than ablate left side.
No junction.
Yeah. Yeah.
Yes.
Yeah, because you want to ablate left side rather than CS if you have junction rhythm because you'll be closer to the head. So that's why I said when you have AVNRT, AVRT, difficult posterior septal case, please the venogram, CS venogram. Find the anatomic relationship between CS mouse, compact AV node, his bundle catheter. You can have a better idea what you can do safely. Okay.
Dr. Deon Kim, why do you think that you successfully ablated the left side posterior ablation first, but it recurs? What is reason?
Number one is content. And I think
You burned it many times, and that was the many red spot.
I felt it was really a broad connection.
Yeah, very connection. That's what it is. Yes.
Sometimes the reinsertion starts from the MCB area and spread the right.
So if you have a postural subtaxial pattern, you think you really have to have a good anatomic assessment of that particular heart because every heart different. They're not same. And then if you miss, for example, Dr. Pang mentioning CS aneurysm, ostium aneurysm, for example, circulation flow and things like that, you may want to look at that area first before you start ablating, and then right and left, the left side, and then we put together, and then you make a decision where you ablate. Because the MCB problem is that if you burn too many times, they can stenosis, then you can never get in there. So I think before we start burning, make sure that this is a target area, and then you really have to burn minimum number of RF ablation in that area. Because the CS also, and then MCB can stenosis, okay? Just to be safe. And the last comment is if you really postural subtaxial pathway, you may think about doing coronary angiogram, right coronary angiogram, because the posterolateral branch of RCA right across that MCB posteriorly. So you don't want to cause stenosis of that thing. And a lot of times those occlusion of the posterolateral branch, they're small. They don't manifest like acute MI. But if you do follow-up angiogram, you'll be surprised. 90% stenosis. We learned that early days. Matter of fact, one of my patients at acute MI went to Oklahoma. So we learned that really hard way. Yeah. So
Initially, I thought this case was a mid-septal bypass stroke because the Pagma shows
I say.
parhesian pacing in every kind of diagnosis.
But I think it's a good maneuvering
Yeah.
because that's what you should do. Make sure that you got the right answer.
Differential diagnosis.
Yeah. So
One last question.
Yes.
Maybe not last, but it is very important question for fellows because it is the CBT. It is easy to differentiate. If it is a patient with excitation with mid-septal bypass, right? Especially referred from other hospital, we don't know the previous operator already made a hot block, and the delta wave still exists. So, do you have any differential diagnosis method before ablation?
well, two things. You obviously want to know the baseline conduction is important. I think of how much injury you have patient had. It doesn't matter who did. We all make a mistake. So first, reassess the avionic conduction curve. Make sure that the conduction still persists safe. Okay. Second is that you want to look at if possibly they had a tracing from the previous case. I think that would be very important for you to minimize your procedure time and then be more efficient. Korean people, they just describe one single page report, send it to you. That is not really, especially it's a high-risk patient, doing any favor for the patient. So those, I think we need to change for the fellows, document well, pictures and so on. Okay. Pace maneuvering, if it's antoge conducting pathway only, you have to ablate in the sinus rhythm or pre-excited rhythm. One thing that you want to make sure that if pathway ERP is longer than AV node ERP or shorter than AV node ERP, that would make a huge difference in your life. Because if you have a lucky day that your pathway ERP is longer than AV node ERP, then you can find a way that pathway ERP, and then every time before you ablate, when your ablation signal is good, block the pathway to say that he's responded yes or no. That's easy to do. Challenge is going to be with the pre-excitation, but then pathway ERP is shorter than AV node ERP. You're out of luck now. Then my advice to you is that go try to go much as possible ventricularize the catheter. Don't try to ablate the atrial side. For that regard, you're going to map the right side septum and the left side septum, both sides. Then you make a decision what to ablate. But my experience, left side septum is an equal quality of a pathway potential timing. Left side is safer than right. Because right side ablation, your catheter may move, come back, and then you end up hurting compact node. Left side, no. His bundle is much more refractory to the ablation because they are so. Second, how do you insert the catheter? If you're going to cross the aortic valve, you got to keep the maintain catheter pointing straight down, never curve up. Because if you curve up, you're going to point to the his bundle. Okay, so you're going to straight coming down and counterclockwise deflecting. Then you want to see the his bundle proximal electrode. This side has no his bundle. Safe to ablate. Because your catheter spacing, remember, 4 millimeter tip, 2 millimeter, 2 millimeter ring, 8 millimeter distal ablation. Then you got 5 millimeter, 2 millimeter ring. So you got at least 5 millimeter away from his bundle. So don't worry that if you record the left side his bundle, the proximal electrode, this has nothing, save the blade. But if you have a far field and distal, answer is no. Okay, that would make a safe tip. Yeah. And then typically mid-supply pattern in the left side, you're gonna need only 25 watts, not more than that. That very quickly goes away if you're the right spot. Okay. So those are safety tips to be do. But if you have the VA conduction, then you can check the VA conduction as well to make sure that one you're recording the pattern potential, not the A. Okay. So bottom line that try to not to do fellows your case in hurry. Don't. You don't learn anything. You will not have any really rational thinking because you're complex. You're very much busy of moving catheter doing things. Take a time. Look at the case. Last thing I ask you again, if you do case, make sure you review every single heartbeat in EGM. Otherwise, you're not going to observe things that you can get out of that case. Your patient is the best teacher. Okay, I can tell you that right now. Not your mentor, not anybody else. Because every heart is different. That's the reason. I never seen your patient's heart, so I cannot tell you all. Okay. So this is important message that you need to get across. Okay. Anything else? We learned a lot today. Thank you so much for bringing interesting cases.
Thank you. septal 바이파스 백인데 앞으로 만드는 데를 보내죠.